Statins are great drugs. They've been promoted for the wrong reason. And of course, we've got great studies that show exactly what I'm talking about. We've got tons of studies showing how statins reduce the quote inflammation that you see from the cytokine. But of course, anytime you stop the trapping, what are you going to do with that inflammation? The immune system gets turned off. So of course, they've got studies showing how they reduce CRP, etc. The reason they reduce it because they stop the trapping. It's a trapping that causes the immune system to kick in and causes the inflammation. And we don't think it's a fair term to say, oh, now you got endothelial dysfunction. No, the body's trying to clean up this mess. If you stop it from being trapped, it doesn't need to do that. The oxidative stress amount, like we said earlier, it's changing constantly in the body. So it's not, well, only 2 days a week I get oxidative stress, I'll take care of it, go to the gym. No, it's happening all the time.
Welcome to the Performance Initiative Podcast.
Our goal is to provide you and ourselves with the tools to be the best versions of ourselves.
We are your hosts, Dr. Grant Cooper
and Dr. Zinovy Meyler.
We just finished speaking with Dr. Brad Bale. Dr. Bale is an expert at heart attack and stroke prevention.
Yeah, and we covered so much ground. You'll really want to listen to the whole conversation because one of the most shocking things that you may find out initially is that you can have a clean bill of health from a regular standard checkup and yet still be in clear and present danger of having a heart attack or a stroke.
Yes, it's scary but very important stuff. Yeah. And you can actually, he teaches us how we can prevent these things very effectively. Also, did you know that there is a blood test that is the most predictive of heart disease? And it's actually not in your standard lipid profile.
Yes, and speaking of lipids, statins are some of the most commonly prescribed medications, but some may actually have more harm than good.
Yeah, that was interesting to find out. Did you know that taking vitamin E can either be great for you or it can actually be harmful, and it depends on your blood sugar status and also on specific genetic tests that you can get done.
Yeah, some of the more shocking or interesting things may be to find out that a provider that potentially can prevent your heart attack is not necessarily your cardiologist, but may actually be your dentist or your hygienist.
Yeah, that's a great point. There was so many enlightening features. We thought, having gone through medical school, that we sort of knew what we were going to be reading about in his book. I had a decent handle on it, but in Dr. Bale's and his co-author Amy Donin, their book Healthy Heart, Healthy Brain, they describe sort of the evolution of the science of prevention of heart attacks and strokes. And in this interview, Brad he really takes us on a tour of that, explains where heart attacks come from, answers a lot of interesting questions, and how we can all take control of our own health and preventing these kinds of things in the future.
Yeah, and the fact that cardiovascular disease affects everyone and everything and is the sort of the hallmark of your health and is also hallmark of aging. This is a longer conversation, but you really would want to listen to the whole thing because there are specific actionable pearls every step of the way.
100%. And it's not just about adding years to life, but also adding life to years. It's a really comprehensive conversation. We think you're really going to enjoy this one. Enjoy. Brad, welcome to the show.
Well, thank you, Grant. I appreciate you and Zinovy inviting me on.
Now, thank you so much for taking the time to have this conversation. Now, we graduated medical school in 2003 and 2005, and we thought at the time that we had a good understanding of the hallmarks of cardiovascular disease, including like what blood markers were important, the different types of cholesterol, etc. Your book, however, was depressingly enlightening.
That's very true. Yes. We learned that you can have a young adult with what ordinarily be considered normal blood pressure, good lipid profile, healthy lifestyle, may even be a great athlete. And yet that very same person can be days or even hours away from a life-changing, perhaps even a life-ending event, right? So like a heart attack or a stroke. So how does that happen?
Yeah, I think to really understand where this information comes from, it's prudent to understand the first step in forming arterial disease. And we're biased, of course. We would argue arterial disease in general is the greatest human ailment that we have. It not only produces those symptomatic heart attacks and strokes, which can be devastating and fatal, but it actually also creates all the chronic diseases of aging, including dementia, heart failure, kidney failure, macular degeneration, peripheral arterial disease, erectile dysfunction in men. And it's all anchored in arterial disease. And what we've been able to do over the last 20 years is develop a method that can halt arterial disease and actually regress it. And the way that we can do that is by stopping the first step in the production of arterial disease. If you want to avoid a problem, the first step is to avoid the first step toward having that problem. So I think it's critical that the listeners understand what actually is the first step when you start to develop arterial disease. And a lot of healthcare providers still aren't up to speed with this because this information was only published about 15 years ago. And it usually takes about 25 to 30 years before that type of information gets introduced into medical schools, etc. But the first thing that has to happen is the cholesterol particles, which do form the bulk of arterial disease, have to get trapped in the wall of the artery. And a lot of healthcare providers still under the illusion that the first thing that has to happen is that the inside lining of the arteries, fancy name endothelium, we like to call it the tennis court, because if you took that single layer of cells out of all your arteries, which make up about 30,000 miles in your body, you could easily cover 3 or 4 tennis courts. But a lot of people believe the first thing that has to happen is the tennis court has to become dysfunctional and inflamed to allow the cholesterol to pass through it into the wall of the artery. And that's not correct. All the cholesterol particles are so small that they can easily pass through a healthy endothelial cell. They just go through the cytoplasm of the cell into the wall of the artery. The only particles that are so large that can't happen with it are the chylomicrons, which are huge and only present briefly after we eat. But all the other particles go right through a healthy endothelial cell into the first layer of the artery called the intima, which is usually devoid of any cells. So they can easily, of course, pass right through that. Then they hit the next layer, which is the medial layer, the smooth muscle cell, and they go right through those cells. Then they hit the outside layer of the wall of the artery called the adventitia. They go through that, and then they get picked up by the lymphatic and venous system and recirculated. So that's what's happening in healthy bodies all the time. So in order to form arterial disease, you have to retain and trap those cholesterol particles in that intimal layer, the layer right below the tennis court, the endothelium. That's the first step in forming arterial disease. So then you say, oh, okay, well, how do they get stuck there? They get stuck by something called a proteoglycan, which has a protein core polysaccharide chains, and the polysaccharide chains have a negative charge, and all the bad cholesterol has woven into it a protein called APOB, which contains a positive charge. So they get trapped electrostatically. It's magnetism, basically. So then you'd say, well, what creates the proteoglycans in the intima to trap them? That comes from genetically transformed contractile smooth muscle cells in the medial layer. They get genetically transformed, then they migrate into the deep layer of the intima, and they secrete these proteoglycans, which will trap those cholesterol particles, the ApoB. So then your next question should be, well, okay, well, what makes those smooth muscle cells genetically transform? That's very important, right? By far and away, the number one reason for that is something we call oxidative stress. Oxidative stress activates platelets, which creates platelet-derived growth factor. Platelet-derived growth factor is by far and away the most common trigger to cause that genetic transformation. So then you might say, well, what's oxidative stress? That's right. Well, in our bodies, we create reactive oxygen species all the time. We need them. And we try to balance them out with antioxidants. Because if you have an overabundance of reactive oxygen species, it's very damaging, and that creates oxidative stress. So we're trying to establish a balance, but when it gets out of balance, you get this oxidative stress, which will then drive that genetic transformation. You'll start trapping the cholesterol particles and start to form arterial disease. So then the next question is, okay, well, what can cause oxidative stress? Well, you mentioned a few that are related, like hypertension, lack of exercise, poor diet. Those will cause oxidative stress, but there are numerous other factors that can cause it. For example, periodontal disease, which is present in about 70% of adults over the age of 60 and 50% of adults over the age of 30. It's very prevalent. That causes oxidative stress. Another thing is poor sleep. So you can be in great shape, but if you're not sleeping well, during the night you generate oxidative stress. Another issue is low vitamin D. If you have a vitamin D deficiency, you develop oxidative stress. If you're overweight, of course, you have oxidative stress. If you have any kind of chronic inflammation going on or autoimmune diseases, you have oxidative stress. So all of these issues, air pollution causes oxidative stress. Radiation causes oxidative stress. Psychosocial issues, stress, and depression cause oxidative stress. And we have very sophisticated research studies that point that out in sophisticated ways. So there's a ton of research to back up everything I was just saying. If you're pre-diabetic or insulin resistant, so to speak, you have oxidative stress. So the reason somebody who appears to be in great health on the surface could still be at risk for a heart attack or a stroke, there are many other reasons that you're not going to be aware of just looking at that person. Maybe they're not sleeping too well. Maybe they do have periodontal disease. Maybe their vitamin D is too low. Maybe they live in Los Angeles, California. I think there's a little bit of air pollution there. Maybe they need to move. Maybe they have autoimmune diseases. And then there are some genetic influences that predispose people to extra oxidative stress. But the key to shutting down arterial disease is to shut down oxidative stress. So stop oxidative stress, SOS.
Yeah.
So it's kind of a new meaning to that old Morse code distress signal. Every human should want SOS, stop oxidative stress. But it reaches way beyond just those conventional, well-known risk factors of cholesterol and blood pressure.
Right.
And even exercise, which is extremely important, and diet. So I don't know, that's kind of a long, involved answer.
No, that was terrific.
It's great because you gave us a foundation of essentially kind of the first step. Just like you said, that's the important part. So if you don't mind, just for our listeners to have a better understanding of how do the heart attacks or strokes happen? You know, you've mentioned the first step. What happens next to actually create the result?
Yeah, to be at risk for a heart attack or stroke, you have to have already formed arterial disease. So you have this collection of cholesterol, which is the main ingredient in the wall of the artery in that intimal layer. And when the cholesterol is being trapped, it turns on the immune system, because obviously the body wants to try and clean it up. So as soon as you start trapping those cholesterol particles, the innate and adaptive immune system get turned on. So the tennis court, that endothelium, starts trapping white blood cells, which then dive underneath to get into this mess of cholesterol to try and gobble them up and take care of them. But that generates inflammation. The immune system. You get an infection somewhere, you get swollen, you get hot. So if that inflammation persists, it can get to the degree that the tennis court, the endothelial cells themselves, will either just break apart or they'll spot on die. So one is a rupture, one is erosion. So if you get either of those occurrences of the endothelium, the body's response is to form a clot. So you form a clot, and then you block the flow of blood with the clot. It's not the cholesterol buildup that blocks flow of blood. We've known that for over 40 years, but there's still some people I think who think that. Oh, to have a heart attack or stroke, you just have to keep building up and building up all this cholesterol in the wall of the artery. Finally, it builds up so much blood can't go by it, and you have a heart attack or stroke. Wrong. That was proven in published New England Journal of Medicine almost 40 years ago. It's a blood clot that blocks the flow of blood. So a lot of these heart attacks and strokes are occurring from disease in the wall of the artery, this cholesterol buildup that's not blocking the flow of blood at all. But if enough inflammation occurs, then you get that rupture or erosion, you immediately form a clot. You block the flow, so then you have your event. And that's why we all know people who, they put them on a treadmill. Oh, we're worried you might have a heart attack. Well, some people basically burn the treadmill up. They stay on it so long the belt melts, and they're patted on the back and told, oh, you're fine. And then a few hours later or a couple of days later, they have a massive heart attack. There's no mystery to that, because most events occur from cholesterol buildup in the wall that's not obstructing the flow of blood at all. You're not going to find it on a test like that.
Friends, we hope you're finding value in the content. If you're enjoying what you're watching, please consider hitting the like button, help us with our YouTube algorithm, consider subscribing to the channel, and turn on the notification button to stay up to date with everything going on in the channel. Is it right to think that most heart attacks occur the way you just described, but that, because the way that I read it from your book was that about 60% of heart attacks occur the way you just described it, but that about 40% are still thinking that it's the plaque buildup that's slowly no, that's not right. So like that's, but is it irrelevant how much plaque is built up in is that like just not something to worry about?
Well, the body's smart. So when you start trapping the cholesterol particles, the outside wall of the artery stretches to allow the hole to stay the same size. So 99% of all buildup in the wall of the artery is actually what we call remodeled, so it doesn't block the flow of blood at all. Dr. Nissen proved that with his intravascular ultrasound, probably 15, 18 years ago. So most all the disease in the wall of the artery is actually going to be invisible to even like an angiogram. And again, that type of disease, if you get enough inflammation where the endothelium breaks or erodes, you're going to get a clot and you're going to have an event. There are very, very few lesions or events that will ever occur because the cholesterol builds up so much it blocks the flow of blood. That happens so slowly that the body, again, is smart. If you do keep continuing to build it up and you can't remodel anymore, you can't stretch anymore this way, it starts to come into the lumen. That happens over such a long period of time that you'll develop new arteries around it. So you can actually totally block off a big artery with the buildup of cholesterol and still not have a heart attack. Because you've got angiogenesis.
Right.
Your body builds new arteries around that. So no, almost all events are due to a blood clot.
So it's kind of, so I hear everything you're saying. I'm fighting what I'm remembering from medical school and trying to reconcile this. So let me ask you, so what I remember from like residency in medical school is we would often order Dopplers of like the carotids, right? And if they were occluded to a certain extent, then they would be treated. That's just archaic, is what I'm hearing.
That's not the way to find out if you have disease. A B-mode ultrasound of the carotid will find disease, and it doesn't need to be obstructing at all. You can see it with that type of ultrasound. The duplex scan of the carotid, which you're referring to, it's only going to show you if you have significant buildup of cholesterol on the wall of the artery. And that's, again, it's the clot that causes the events. It's not the buildup of cholesterol.
Right. And it just seems that, and certainly it makes sense, and can't stress enough the fact that the idea and the concept of what you're talking about and the importance of that is that with routine scans and routine studies, you're not going to see it, and you can have a clean bill of health, so to speak, and still be developing arterial disease. And that's why this is so important. What about the idea of the peripheral vascular disease in the extremities, where there is, the vascular claudication? That's a buildup of plaque and the combination of sclerosis and stenosis of the vessels, correct?
Well, some of that you probably have had silent events in bigger arteries like the femoral arteries in the leg. And these, we now know silence events are as common, if not more common, than a symptomatic event. And in these silent events, you get the injury to the endothelium. You form a little clot there. It's not big enough to block the flow of blood. Some of those clots will peel off, and they'll travel downstream till they get stuck in the tiniest arteries, arterioles, or capillaries. And there they will kill some tissue, but it's just a few cells. You don't know it. You're not aware of it. The other thing that happens when you have that injury to the endothelium, where you can form a tiny non-obstructing clot, which can peel off and go downstream to cause disease, you activate platelets when that happens. So some of those activated platelets can end up causing some obstruction in the tiniest arteries, again, arterioles or capillaries. So, and when that happens year after year after year, eventually it's like, yeah, I've got peripheral arterial disease. I've got an issue with my feet or my hands. It's the same thing with macular degeneration, the same way it occurs: heart failure, dementia, erectile dysfunction. It's all due to microvascular disease.
And that
now most of the experts believe that the pathogenesis of most all chronic diseases of aging rests with microvascular disease. And that's something my partner and I certainly didn't realize when we set out over 20 years ago to stop heart attacks and strokes. We were just concentrating on the symptomatic ones. But the main reason for our newest book, Healthy Heart, Healthy Brain, was we noticed after doing this for 20 years, not only were patients not having any heart attacks and strokes, but the dementia risk is minuscule. People aren't getting heart failure. Men don't get erectile dysfunction unless they already had it when we first saw them. We've had no kidney failure, macular degeneration, peripheral arterial disease.
It's remarkable.
When you shut down arterial disease, when you stop that first step by managing the myriad of things that can cause oxidative stress, you're not going to get any of those issues, including peripheral arterial disease.
Yeah. And to give it a unifying theme of the high and the erectile dysfunction and the peripheral vascular disease, we would imagine that the organs that are supplied by the smaller blood vessels would be the first to be affected because they'd be more sensitive to the small clots.
Every organ is supplied by the smallest vessels. Every cell in your body is supplied by the smallest vessels, capillary. Your cells aren't supplied by these huge arteries that get clogged and cause a heart attack.
Right, but the ones that don't have as much peripheral, that don't have as many different vascular spots supplying them are going to be, like in the eyes, would be more sensitive or not necessarily?
No, not in my opinion. Every cell in the human body depends on arterial blood flow. That's what brings in the nourishment and takes away the waste. Every cell in the body. So
they're all sort of
uniformly
exposed to the risks.
Yeah, it's just the heart attacks, symptomatic heart attacks and strokes, of course, have gotten all the big attention because heart attacks are still number one cause of death. And dementia and strokes are huge issues causing disability. But all these other issues are also anchored in arterial disease. That's what's so exciting to us. That's why we published the latest book, because people need to understand you can stop arterial disease. When you stop arterial disease, you put an end to all these things we were just talking about. And when you stop oxidative stress, you're going to live longer. One of the things that shortens your lifespan is oxidative stress. It causes premature senescence, where this DNA can't divide anymore, so the cells die. So oxidative stress is critical for longevity. So just to give you a simple example, it was, I think, 5 days ago now, a patient that I started seeing 17 years ago, at the time he was 75, he'd already had several heart attacks, had stents, and he's a type 2 diabetic. And he was 75. He just turned 92 5 days ago, and he's surrounded by his family, including his children, grandchildren, great-grandchildren, and his girlfriend. And he's still so smart, he's on the bank board. He's 92. He's a type 2 diabetic. When you shut down arterial disease, that's what you can expect. We're all going to die someday, but you don't need to die with all these chronic diseases that are rooted in arterial disease. It's wonderful news. I mean, people should be excited about it.
Well, and it is.
People are probably thinking I'm crazy.
No, it's very important.
Of course, the medical establishment would be done. You mean there's a cure for arterial disease and they're not teaching it and doing it? Yeah, that's the truth.
Well, one of the things, just to highlight one of the things that you mentioned, and just for our viewers and listeners that are not aware of why you were highlighting the type 2 diabetes, which you said a couple of times, and that is a very, very important thing because we think of type 2 diabetes as something that is a microvascular disease, right? Where that's why people get peripheral neuropathy, as when they have type 2 diabetes, they're at risk for that because diabetes is causes glycosylation, and then that causes glycosylation and then constriction of the microvascular bed that supplies those little nerves, and then they start to get that peripheral neuropathy. And then, of course, to your point, that causes additional lack of supply to all the other organs. That's why you're highlighting that he is the type 2 diabetic, which is that much more impressive. Yes.
Yes, I mean, if you can stop it in a type 2 diabetic, you can stop it in anybody.
Right.
And I would argue he may be the oldest living type 2 diabetic in the country, if not the world. He's 92.
Right.
He's doing great.
Well, especially if you've had type 2 diabetes, because diabetes is all about time since diagnosis, right?
Yeah.
So if he's had it for 17 years.
He'd already had coronary artery
Right.
disease by the time I first saw him.
Right.
Yeah. And the really exciting thing is not just the longevity, but what you said before about longevity with better health throughout the time.
He's got a great sense of humor. When I called him to congratulate him on his birthday, he was actually in the gym working out.
So decreasing arterial disease improves your sense of humor too. So that's an important thing too.
Humor helps combat oxidative stress.
The other way
We
around.
have studies showing if you're optimistic, you're going to live longer.
Yeah.
Why are you going to live longer? Because you have less oxidative stress.
Right.
When you're pessimistic and unhappy all the time, it generates oxidative stress. That's going to shorten your lifespan. It also increases the risk of cancer. Cancer is related to oxidative stress as well. And we have well-published studies showing when you do what you need to do to stop arterial disease, at minimum, you cut cancer risk in half.
That's
Yeah.
dramatic.
And so I think this is a good time to go to the next question that we had, and that is, well, let's start with the fact that you're a big proponent of personalized care, right? And specific to the individual. And so to that end, we wanted to find out who would you say is at risk and how do you find out, right? How do you do the diagnostic workup and identify the specific risk factors?
Yeah. Yeah, we've been anchored in genetic testing from the get-go for over 20 years, and there are some genes, and that field, of course, keeps expanding, which when you're positive for some of these genes, we know right off the bat you're more apt to develop arterial disease, more apt to have a heart attack or stroke, etc. And as we learn more about the gene itself, it opens the door more for individualized management. But certainly when we know that somebody's genetically more apt to have disease, we want to make sure we're covering all the bases of the root causes of oxidative stress immediately to help minimize their risk. And then there are some targeted therapies that can be related to some genes. And I'll go back to the type 2 diabetics. And we published this study in Frontiers of Cardiovascular Medicine several years ago. But there's a gene called haptoglobin gene, which we've been measuring for a long time. And you're either haptoglobin 1 or haptoglobin 2. You get one from each parent, so you can be a 1-1, 1-2, or 2-2. And I won't dive into all the deep science on it right now, but I'll keep it simple. We've known for a long time, if you're a type 2 diabetic and also haptoglobin 2 genotype, you have 10 times the increased risk of a heart attack. 10-fold, as opposed to being a 1-1. And if you're a 1-2, it's about 5 times more likely to have a heart attack. So, and about a third of all people are haptoglobin 2. And when you look globally at the numbers, that translates to there are about 80 million type 2 haptoglobin 2 diabetics in the world who are extremely predisposed to heart attacks. And there are two simple things that can almost bring them back to normal risk. One is if they take vitamin E, 400 international units, alpha tocopherol, and that was published in a randomized double-blind placebo-controlled trial published in one of the best cardiovascular journals probably 10, maybe 12 years ago, ATVB, atherosclerosis, thrombosis, vascular biology. It's a shoot-off of the American Heart Association. They clearly showed that the patients who received vitamin E, who were type 2 diabetic, haptoglobin 2, it almost brought them back to the risk of a 1-1. In addition, we also know that those individuals need tight glycemic control. so they need to keep their A1C under 7. That has a huge impact on their risk for having heart attack if they're type 2 haptoglobin 2-2. So in the paper we published, the genetic test costs like $40. We said it should be malpractice to have a type 2 diabetic that you don't know their haptoglobin gene type. Because a third of them are going to be 2-2. You can clobber their risk of heart attack. Vitamin E, what's that cost?
Right.
Yeah.
It's nothing. And they're the ones that need tight glycemic control. You know, the endocrinologist several years ago kind of loosened up on that because some people get harmed if you push too hard to try and control their sugars. There can be harm, but if you're going to push to control sugars, the ones you absolutely need to are the haptoglobin 2-2 type 2 diabetics.
Right.
Yeah.
So,
Is it,
I mean, it's unbelievable to me that isn't, it should not only be the standard of care, it should almost be a law.
yeah.
Really, you'd think the insurance companies would want them to be genotyped.
How widespread is the genotyping? Do you have any sense of it?
Oh, I mean, it's easy to get. We've been getting
No, I mean, how widespread, like, are people ordering it? Is it common for doctors and cardiologists to order that?
probably more so. I mean, anybody who does our method certainly orders them.
Well, after this podcast, everyone's going to be getting it, so we'll solve that.
I mean, in the type 2 diabetic, I mean, that in my opinion, there's no excuse. If I was a type 2 diabetic, I'd be demanding that my healthcare provider got my haptoglobin genotype. And that's just one example with one gene.
Is it right to say also that if you're not haptoglobin type 2 and you take vitamin E, it's actually bad for you, right? That's why it's so important to know.
Correct. We have the studies to show that. If you're a type 2 diabetic, haptoglobin 1-1 or haptoglobin 1-2, and you take vitamin E, it's harmful.
Do we have any idea why?
Blind, oh, you're a type 2 diabetic, take vitamin E. No, you got to know the gene.
Yeah.
And we know the scientific reason for it. If you want to know that, you can read the paper we published several years ago.
Yeah.
And again, guess what it relates back to? Oxidative stress.
Right, right.
Because the purpose of haptoglobin, it's produced in the liver, is it's supposed to rush out and grab free hemoglobin, which is being released in our bloodstream all the time because red blood cells have a rapid turnover. And that free hemoglobin contains iron, which causes oxidative stress. So haptoglobin is supposed to rush out, grab it, take it to a white blood cell. It gets broken down into basic elements and recycled. Haptoglobin 1-1 genotype, very efficient at that. The haptoglobin 2 is a genetic misfire they figured 2 million years ago in India. The only mammals that contain haptoglobin 2 are human beings. Haptoglobin 2 is not near as efficient at grabbing free hemoglobin. And haptoglobin 2-2 compared to 1-2 is even worse at grabbing it. But it has an affinity, haptoglobin 2, for HDL cholesterol, the quote, good cholesterol. So it will grab, haptoglobin 2 will grab some free hemoglobin, and it will take some to white blood cells, but it's going to take a bunch to HDL. Then in HDL, the iron gets deposited, and HDL creates oxidative stress and destroys HDL's ability to do reverse cholesterol transport.
Fascinating.
I tell you, oxidative stress, we published that paper. Hopefully you've read that in Frontiers of Cardiovascular Medicine. Did you read that paper?
No.
I'll have to send you the link. It's already ranks above 90% of all articles ever published in all of the Frontiers journals, not just Frontiers of Cardiovascular Medicine. It's had over 13,000 views and downloads, and the scientific community's really excited about it.
That's amazing.
One of our providers basically said, well, that's a Rosetta Stone
Yeah,
for arterial disease.
that's fantastic. I mean,
So
Yeah.
I'll send you that.
yeah, please,
Please,
that'll
yes.
be great. That'll be great.
And if that's okay, we'll put a link.
Yeah, we'll put a
Link to it.
Okay.
Yeah, so people can find it. Yeah.
But I mean, I get so wrapped up and passionate about all this. And the exciting thing really is you can stop arterial disease in any human being. It's the biggest ailment in the human body.
Yeah.
All of these other things that we hear about, the chronic diseases of aging, they're anchored in arterial disease. When you shut it down, they're not going to happen.
Yeah, it's so exciting, and it must be very frustrating because you want the word out there. Yeah. Can we talk about the different labs? Like if you're someone who wants to know their risks, right, for other than the lifestyle risk factors and the comorbidities, what kind of lab work should people be getting?
Well, in terms of the cholesterol, the APOB is the one that we've got over 40 years of evidence saying that's the number one predictor of risk, not LDL cholesterol. We've got study after study after study showing that. And as a matter of fact, I think it was a year and a half ago, in one of the cardiology journals, they actually published, we've got over 40 years of evidence telling us ApoB is the most predictive cholesterol measurement. If we don't start using that, we can no longer claim we're practicing evidence-based medicine. But it's still not in the guidelines, folks.
Right.
Do you know your ApoB?
I do not. Yeah, this is one of the things I was so amazed at because
What's it cost? $10.
Right.
Yeah.
But guess what else? Statins don't necessarily take care of ApoB. You think that might have something to do with the guidelines?
Hey.
Statins take care of LDL cholesterol.
Right.
But there's study after study I can share with you where they looked and found the LDL reduction had nothing to do with the risk reduction from the stat.
Yeah, that I've heard. Yeah.
And if you know the first step in causing arterial disease, of course you're going to know ApoB is going to outpredict LDL cholesterol. What gets stuck on the periodontal? ApoB carries a positive charge. So people need to know what their ApoB is, but they have to also understand a lot of healthcare providers don't really even know about it.
Right.
Because they just go by the standard of care. Oh, it's just measure LDL. And then the other one that's the mass murderer, that's the inherited lipoprotein A issue, which you are starting to hear more about now because they're developing what I'm sure will be extremely expensive medications to clobber lipoprotein A. It's inherited, has nothing to do with your diet, exercise, anything else, and we've known forever. We even have genetically based studies showing it causes arterial disease. Those studies were published 14 years ago in JAMA. When they came out, Dr. Michael Lauer, who was head of the NIH at the time, came out over the medical airways and said, look, doctors, lipoprotein A causes heart attacks. Would you please measure it and do something about it when you find it? You might as well have been talking to a brick wall. It will eventually get into the guidelines once they have these extensive medicines to take care of it. But we've been managing it with niacin, which they just tried to publish a study recently. Said, oh, niacin produces too bad metabolites. It can increase risk. Niacin is one of our secret sauces we've been using for 20 years. Guess what? The 92-year-old type 2 diabetics, one of the things he's on is niacin. Niacin clobbers oxidative stress. So yeah, maybe there are a couple of little metabolites that increase. You have to look at the whole picture. Everything has good and bad, right? Every medicine is a poison. When you use it, you're betting the benefit outweighs the harm. So I'll take those two little metabolites all day long for all the benefits that niacin provides, and it will lower lipoprotein A some. It won't normalize. And in Europe, that after those studies were published, they actually put it in their guidelines for every adult to have lipoprotein A measured. And when it's elevated, guess what they said to treat it with? Niacin.
Niacin, yeah.
Well, that's vitamin B3, folks. There's no money in it.
Yeah.
And then how long ago was that? And have they seen any change in their statistics? Or it's too soon, probably.
I'm not sure about change in their statistics. I can tell you, and that was about 14 years ago. But I know we've been measuring it for over 20 years. We've certainly had patients that came to see us for the first time after they'd had a heart attack or stroke. Then we found out they had lipoprotein A. None of them have gone on and had another event.
Is niacin just good for people with lipoprotein A, or should everyone be taking it because it lowers oxidative stress across the board?
No, everybody shouldn't have to take niacin. The only people that absolutely use it in, or at least try it, some people can't tolerate it. It makes you flush and they just can't take it. And rarely it might cause a liver issue, but that's pretty rare. So the only ones I'd normally recommend it to are with lipoprotein A, and then you start low and just try to slowly build it up. It can have other benefits though, and one of those can be to increase HDL's ability to do reverse cholesterol transport. Because, you know, the absolute number of HDL, the good cholesterol, doesn't mean a whole lot. It's like Einstein stated, a lot of what's counted doesn't count, a lot of what counts can't be counted. We still don't have a clinically useful test to tell us how well HDL is doing reverse cholesterol transport. That's how it protects you with arterial disease. We do have studies in diabetics showing that when they go on niacin, it enhances that reverse cholesterol efflux ability. So one of the reasons I know I put that 92-year-old diabetic on niacin right away, because he was a type 2 diabetic. And I knew his HDL, whatever amount he had, wasn't as functional as it needed to be. So I knew if I put him on niacin, it would help the functionality of his HDL. And it's cheap.
Do you dose it differently based on individuals?
Yeah, I mean, the highest I've ever gone is 2,000 milligrams. And I'll always start a lot lower than that.
Right.
Maybe 500, 250. And then just, because the longer you're on it, the less you tend to flush, the better you tolerate it. But there are a few people that they flush so bad they can't take it.
Yeah.
Just absolutely can't do it.
Mm-hmm.
And it's not like they're going to die if they can't take it, but it can be useful.
Sure, sure.
And it's cheap. But again, lipoprotein A, there's not going to be any paucity of information about that coming out because of the new expensive drugs. I anticipate one of them will be approved sometime in the next year. My guess is it'll probably be $1,000 a month. And about a third of humans have elevated lipoprotein A, so that's a big market.
Do you
I've already forewarned my patients that have lipoprotein A, when it comes out, I'm not recommending it. I mean, some of them have already been treating over 20 years. They're doing fine.
Mm-hmm.
Yeah.
I mean,
Great. Do you still check HDL and LDL and total cholesterol, or do you not worry about that? You just get the apolipoprotein B.
Because all labs do it, we get the basic lipid panel. But the only thing I really personally, and I get APOB and I measure lipoprotein A only once.
Right.
If they haven't inherited it, they won't get it. But the numbers I pay the most attention to are triglyceride. And again, the standard of care is falling short in our opinion on that. They say if it's under 150, that's fine. We want it under 100. And the reason, triglycerides represent remnant cholesterol. remnant cholesterol is IDL, VLDL, and the chylomicrons. These remnant cholesterol particles cause oxidative stress. And the way that happens, they get trapped on the endothelium before they go into the wall of the artery. The lipoprotein lipase interacts with them, creates free fatty acid, which drives oxidative stress. So remnant cholesterol particles natively drive oxidative stress, increase the first step in forming arterial disease, whereas LDL cholesterol, it's well published, it only causes oxidative stress once it gets trapped. Once it gets trapped in the intima, then it generates oxidative stress, but in its native form, LDL is not inflammatory at all. Because inflammation stems from the trapping. That's what turns on the immune system. So we've known and had great studies for years now showing how remnant cholesterol actually is inflammatory out of the chute before it gets trapped. So we pay attention to triglyceride, and then we also pay attention to the total cholesterol HDL ratio. We want that under 3. And our reasoning for that is the studies that have shown regression of arterial disease, including our own, we drive that ratio under 3. If you're going to regress disease, you got to take the cholesterol out, right? What does that? HDL.
Right.
So we pay attention to that. And then we measure APOB. That's what we pay the most attention to. And if somebody's just regular prevention, we want it under 80. If they've already had multiple heart attacks, we want it under 65 or 60.
And basically, the lower the better. There's no too low on the lipo-B.
If you get it down to 80, you're probably fine.
Yeah.
Again, we've all heard, and I'm sure you learned this in medical school, it was always kind of puzzling how we knew half the people who had horrible cholesterol their whole life never had a heart attack or stroke.
Yeah.
Then half the people having heart attacks and strokes had always had really good levels of cholesterol. Well, you should understand why that's not a puzzle anymore. It depends on how many proteoglycans you have in the intima. If you're not forming oxidative stress, you're not transforming those smooth muscle cells, you have no proteoglycans in the intima, you could have an ApoB at 200. Right? So what? It's just going to flow right on 3. But if you've got a bunch of proteoglycans, you still are transforming a lot of those contractile smooth muscle cells because you're not sleeping, you're psychosocially messed up, you low vitamin D or an air pollution, etc. You can have an ApoB of 60 and still have another event. You got to shut down the trapping.
Right. Yeah.
To shut down the trapping, you got to stop oxidative stress. So, but in the studies, they keep concentrating on LDL. So
Yeah.
oh my gosh, they're really high risk. They've already had 4 or 5 heart attacks. They got 20 stents in their hearts. We got to clobber that LDL and get it below 50 or whatever. No, you have to manage all the oxidative stress issues, quit forming the proteoglycans in the intima, and they're going to be okay.
Amazing. Yeah. Makes sense.
And there's no direct way to measure the oxidative stress, correct?
Unfortunately, we have a test we utilize called the F2 isoprostane in the urine, but it really is a gross marker. We kind of nicknamed it the lifestyle lie detector test. It does seem to tell us when somebody has fallen off the wagon with their exercise and diet, but it's not really a fine-tuned oxidative stress test. We actually have a patent pending on something that we think will be a lot better, but it would be nice, because oxidative stress is like the fasting blood sugar. It's changing all the time.
Right.
Yeah.
Right.
So it'd be kind of nice if we had a much more accurate test and you could experiment with yourself, like, oh, I did this, what did it do that? You know?
Right. Absolutely.
Yeah,
in a similar way
just like
that
the glucose monitors. Yeah.
yeah, glucose monitors or trackers, sleep trackers, and
Yeah.
So that may be in the pipeline, you're saying, right? You're working on that?
Besides for those labs, are there other diagnostic tests that you think people should be getting? I'm leading towards the CIMT.
Yeah. Well, to have risk for an event, whether it be a silent event or a nasty, noisy event, you have to have plaque in the wall of the artery. You have to have arterial disease. So we evaluate every patient for the presence of arterial disease. And there are various ways of doing that. Obviously, as we discussed earlier, treadmill's not really a good test. Even an angiogram can miss it. So the test that we go to out of the chute is ultrasound of the carotid, because as a rule, the carotid artery is the last place in the body to develop arterial disease. We're made to protect the brain longer than anything. So if we find plaque in the carotid artery, we're done. We know they have it everywhere, and we've got numerous studies showing if you have it here, you're at risk for a heart attack. You don't need to look at your heart. We know you got it there if you got it here. So we go here first. If we don't find it with ultrasound there, then we move to the femoral artery with ultrasound. If we find it there, same story. We know people who have femoral atherosclerosis are at increased risk for heart attack. So you've got risk, you got disease. If we don't find it there, then we might look at the coronaries. And the coronary calcification test can identify people with disease if it's positive. If you have a positive score, we don't really care if it's 1 or 1,000. We know you've got disease. The weakness with that test is if all of your disease is, quote, dangerous, it's lipid rich, none of it's cooled off to calcify at all, you miss it. So that can be an issue. Just to point out how that can happen, I had a 42-year-old dentist that came to see me a couple of years ago, and when we did the carotid, we couldn't tell from his labs for sure if he's going to have disease or not. We didn't know. So he came in the night before the visit for carotid, and we had him scheduled the next morning for coronary calcification in case we didn't find anything, right? Well, they'd get that. Well, he came in and he had this huge, totally lipid-rich plaque in his carotid. No calcium in it at all, but it was big. So definitely a risk for a stroke and heart attack. He had a family history of it. So I told him, I said, Brian, we don't need to do that coronary calcification test tomorrow. I found out what I need, so we're going to cancel it. I woke up at 2 o'clock in the morning out of a dead sleep. And the only thing I could think of, oh my gosh, I've got to get that coronary calcification test on Brian to prove a point. He'll have a 0 score. All this disease is hot. None of it's cooled off. So I woke him up, I think at 6 o'clock, and said, Brian, I changed my mind. We're going to do that test. I don't need it to know how to treat this. I'm paying for it. Test's on me. There's not much radiation from it. It's like a couple of chest x-rays. So took him over there. I paid for the test. I'm visiting with him about 2 hours later. Yeah, the score comes in 0. So he's a perfect example of if a physician had only done that test, like they heard about coronary calcification, well, that'll tell us if he has disease. That's what I'll do with Brian. Comes back with a 0 score, he probably would have had a stroke or something in the next few years. So,
Yeah.
now CT angiogram is a different story. And you can get AI attached to it now with something called Clearly. And that can find even uncalcified disease in the coronary arteries. Obviously, it's a lot more expensive.
Right.
And if somebody does it, I would recommend overlaying the AI on it because it really enhances if you're going to pick something up. So if we had a patient that we really just couldn't believe they didn't have coronary disease for whatever reason, and I wanted to be even more positive, I'd order a CT angio with AI overlay on it. And then if that said they didn't have anything, so no, they don't have anything.
Something that I found really interesting and really drove home the point from the book was you described a patient who had more hot lipid disease. And you said like you followed, I think it was you followed the cardiac calcium score and you expected it to go up as you treated him because it was all being calcified and taking it. And I thought it just really brings it home.
Yeah, that study's been published. Yeah. As you regress disease even and you cool it off, the calcium score goes up. So, I mean, before we started doing carotid INT 23 years ago. And prior to that, we were doing coronary calcification because we were fortunate in Spokane, who started, Dr. Paul Shields, was an adult cardiologist there, and he purchased one of the first pieces of equipment to look for coronary calcification. It was electron beam tomography. So I went to one of his talks, and he said, look, this is an inflammatory disease. We can do this electron beam tomography of the heart. If you see calcium in there, we know they have plaque in the heart. That puts them at risk. You should treat them and try to follow inflammation. At that point, all I could order was CRP. But so we were new to the test, and what we noticed, incidentally, after several years, we'd have a patient repeat it. Well, their score went up. Turned out that was good. But then once we learned about the carotids, like a no-brainer. I mean, you don't need calcium. You can see the dangerous stuff here. So it's a place to start.
Yeah. Nice. Could we talk a little bit about oral health?
Let me just maybe add to that, because
please.
The first thing we do is examine a patient's record, especially with radiography, because maybe they've had a brain scan. Maybe the brain scan shows they've got arterial disease. Maybe they've had an x-ray of their leg for a fracture and they spotted calcification in the arteries.
Right.
Maybe they see the dentist and the dentist does their x-ray and sees calcium in the carotid artery. So, and mammograms even, we've had for years studies showing if a female has calcification in the mammary artery, not calcification in the breast tissue, right? But in the mammary artery, they're at higher risk for heart attacks and strokes. Of course, they got arterial disease.
Yeah.
You have to have disease to have risk. So we did publish a paper just 2 years ago stating how we need to migrate to a ternary prevention category. Right now, in conventional cardiology, either primary prevention or secondary prevention. Primary prevention simply means, well, you haven't proven you got arterial disease by needing a stent, having a heart attack, having a stroke, etc. You got no clue whether you have disease or not, but you haven't proven it. So you're primary prevention. Secondary prevention, yeah, you proved it the hard way. You had a heart attack, stroke, needed a stent. And that causes confusion with simple things like aspirin. Again, it's a clot that blocks the flow of blood. So if we find you have disease in your arteries, do you think we want you on aspirin? Yeah.
Yeah.
I don't care whether you've proven it the hard way or not. Your secondary prevention for us, the ones that proved it the hard way, are tertiary preventions. And the primary prevention are the patients where we look as hard as we can't find disease.
Yeah.
And that's where we need to go with the healthcare system. Right now, it's just primary, secondary, which is crazy.
Right.
It needs to be a ternary system. Primary meaning you don't have disease. We're going to make sure you do our best to make sure you never get it. Secondary, yeah, you've got it. You didn't know it and never bothered you. We're going to make sure it never does bother you.
Yeah.
Tertiary, yeah, you were easy to find out you had disease. You proved it the hard way.
If you see some disease, let's say in like some ancillary study, do you still go ahead and quantify it with the CIMT to risk stratify?
Great question because we do have great data now, and some of it was just published about a year and a half ago, showing just following the intimomedial thickness measurement, aside from the actual cholesterol buildup, the plaque, the change in the intimomedial thickness relates to risk of heart attack and stroke. And this data indicated that if you simply slow down the progression of that thickening, because normal biology, that layer keeps getting thicker and thicker and thicker as we age. If you simply slow it down, you prevent heart attacks and strokes for every 0.01 millimeter, 12% reduction in heart attacks and strokes. And you know from reading our book, our publications show we don't slow it down. We reverse it. It regresses. So we do, in those individuals, follow the disease through carotid INT.
Mm-hmm.
Correct.
Yeah. Nice. And how often would you scan somebody?
Well, that's a great question. And we've been doing it about every year. I've got some patients haven't done it that often, every couple of years. And then occasionally somebody even sooner. Like one patient I had, you talked about obstructing disease. We were shocked in his carotid. He was 95% obstructed. So I sent him to a vascular surgeon. So maybe he does need to be cleaned out before he has a stroke, endarterectomy or put a stent in. Well, the vascular surgeon created some sleepless nights for me. He replied, no, you just treat him.
It's quite a vascular surgeon. Most I think would jump on that. Yeah.
Because he was actually symptomatic. If he put his finger on that carotid, he would get dizzy. So we started treating him. He had lots of reasons for oxidative stress. He was inflamed, so we started putting the fire out. Told him not to put his finger on his. Yeah, I say, I'm not comfortable waiting a year to look at this again. I'll say, I want you back in 6 months. So in that case, we re-examined him with the carotid in 6 months, and he'd had significant regression of the plaque. By that time, it was down to 85%. He had 10% regression in the plaque. And he also went in and told me, yeah, and I notice now if I put my finger in
Don't do that.
He was self-tracking. Yes.
It is the cheapest diagnostic test.
And just to let you know, he was well in his 70s. So, yeah. And he's still doing great. Yeah.
Amazing. Hey, was there a reason that the vascular surgeon didn't want to operate? Because I'm surprised.
I was a little surprised too, but if you look at all the surgical data, there isn't any clear-cut answer on that.
I mean, good for him. Yeah. Okay.
And the patient was still extremely active, mentally sharp, and I think they just didn't want to risk it, and they wanted to see if we could make a difference with their medical management, which we did. So he'll should never have to have surgery on that.
It's great.
Yeah.
But there again, it goes back to what you were talking about earlier. Well, don't some of these strokes happen just because the artery totally gets blocked? Well, of course, in the carotid, even if it gets totally blocked, you got all sorts of arteries to go around it, right? The circle of Willis. So, no, it's a clot.
Yeah. Yeah.
And most of them are silent.
Yeah.
And that's what robs a lot of individuals about 16 years of their life. Most adults outlive their health by about 16, 17 years. And most all of that's due to dementia, heart failure, kidney failure, erectile dysfunction, macular degeneration, peripheral arterial disease. It's all preventable, folks. If you shut down the first step in forming arterial disease, you can not only stop the disease, but then the HDL has time to go in and start regressing it some.
Yeah.
Yeah. I definitely want to go to oral health because it'll be music to my dad's ears. He's a retired dentist. But just one curious question. One of the things in your book, about looking at your face and one of the creases. Can you speak to that?
Yeah, that was that AI study where they looked at the face and would predict your risk.
Right.
Yeah, obviously we're not using that clinically, but it is interesting that they could do that. And we've said for years, and there is AI that can do it now, that the best place to look for arterial disease is the retina. That's the only place in the body you can see the brain and the arteries head on without cutting somebody open. And in Russia, they have developed AI now that you can take photographs of the retina and predict who's going to have a heart attack, who's going to have a stroke, and follow the disease over time. So we think that'll become clinically available, hopefully in the next few years. And that might take away the carotid, quite frankly. In our opinion, I mean, how simple is it to take a photograph of the eye,
Right.
look at those vessels, and apply AI to it?
Right.
But getting back to oral health, you know, the periodontal disease, of course, it's almost as common as arterial disease. And it drives a lot of arterial disease because it drives the oxidative stress, of course. And we published a paper, you probably know, quite a few years ago now, calling periodontal disease the high-risk pathogens actually causal of arterial disease. So, but prior to that, people were associating it. And with association, it begs that you could be a little lenient. Oh, well, we don't know for sure. Maybe we don't really need to take care of it. When it's causal, yeah, you got to take care of it. So all of our patients have sophisticated pathogen testing before we even see them for the high-risk periodontal pathogens. And we run into it all the time. It's extremely common. So we need to get those pathogens taken care of, and we use our oral health specialists for that. And then the oral health specialists are also experts in the airway. So they can get good images now with some of their CT scans, like the 3D cone beam, and know if the airway is getting likely to be obstructed at night when you sleep, which can cause oxidative stress.
Right.
And now we have good studies showing the mandibular advancement devices, if somebody has some obstructive sleep apnea, if it's mild, or kind of low, moderate obstructive sleep apnea, those mandibular advancement devices can work as well as CPAP. So we use the oral health care providers a lot for the airway sleep issues as well. And then we have great studies for endodontic disease, periapical abscesses. That appears, it can be the final straw to trigger that heart attack or stroke. You were asking earlier, what causes, what makes them, why do you get the clot? If you get enough inflammation, you rupture or erode the endothelium. And endodontic disease, we have great studies indicating that can do that. And it will not surprise us if 20 years from now, they show somewhere around half of all acute symptomatic heart attacks are due to endodontic infection.
And you find, and you find some DNA of the bacterial DNA in the clots themselves, right?
Oh, yeah. They've done that for decades and decades. But I think with the endodontic disease, the main reason it puts people at such high risk is because of what we call myeloperoxidase, which you probably are familiar with. Myeloperoxidase is encapsulated within all white blood cells. And when you get an infection somewhere, that white blood cell will travel to it, release myeloperoxidase into the tissue. It then interacts with hydrogen peroxide to create hypochlorous acid. Well, hypochlorous acid will kill any germ. It doesn't matter if it's bacteria, virus, fungus, whatever. And the mouth is so rich with blood flow that we measure myeloperoxidase in our patients. And when it elevates around 9 out of 10 times, it's due to an infected tooth. And we've had studies for a long time. One was published in the Journal of American College of Cardiology. When myeloperoxidase is elevated, all bets are off, folks. You could have a heart attack or stroke any second, but it doesn't matter how great everything else is. It can spot on erode the endothelium. They haven't found anything that's more likely to kill an endothelial cell than hypochlorous acid produced by myeloperoxidase. And it can cause a rupture, which either one will cause a clot. So the dentists, in our opinion, are a vital part of what we do. And we were blown away. I saw a patient last week. We just had to laugh because we sent off for the dental records, but the person that saw the request said they'd never sent us any. So we got a hold of the office and said, well, we wanted those records. They said, well, we saw the request. It said health records.
Yeah.
What? You don't realize what you're doing impacts health? Oh my God.
Wow.
Oh, that was their response. You said health records. So we thought you just wanted medical records.
Wow. Talk about a missed opportunity.
Unbelievable. And then the one we really haven't talked about, because I think it's in its infancy, is gut dysbiosis. It's absolutely important. And I think it'll be fascinating to see how it unravels over the next decade. But it's, in my opinion, like stool tests looking for bacteria counts and stuff. It's still in its infancy, and yes, it's important. And I think we just need to eat foods that we know will enhance the good bacteria, such as fermented foods, kombucha, etc. But
yeah, we spoke with Dr. Remnant Meyler. He's a gut health expert, and it just impacts everything. There's nothing it doesn't touch.
Yeah, and it will cause oxidative stress. Absolutely.
Yeah. Well, given the concentration of the immunity in the gut, as well as serotonin, and of course it'll impact all of those aspects.
Yeah. So we pay attention to it, but I think clinically we're kind of limited at this point.
Sure.
As to
Right.
what we can tell patients to do, other than we know extra fiber is good, the fermented foods are good. It appears coffee actually enhances the good bacteria of the bad bacteria.
That was a wonderful thing to say.
That's a real deal, and it'll be great to watch it unwind over the next decade or so.
Yeah, I think it's really coming into its own also. I think it's ripe for some interesting breakthroughs in terms of how to manage that.
And it definitely plays a role in what we're doing. It drives oxidative stress. So, yeah.
When it comes to lifestyle changes that people should be making, do you have some general recommendations people can take?
Well, in terms of physical activity, we always tell patients the minimum we expect is an equivalent of a 22-minute brisk walk every day. It doesn't have to be a walk, but the equivalent to that. And then they have to work all the major muscle groups at least twice a week. And the more they do, as a rule, the greater the benefit. But the biggest bang for the buck is with that recommendation. If they do more, they get more. But physical activity is one of the best ways to combat oxidative stress. And we have detailed science pointing that out. Not only does it decrease reactive oxygen species, but it increases antioxidants, much more likely to get that balance that you need. So physical activity is absolutely necessary. And obviously, from the work you do, some people are limited in what they can do, but everybody can do something.
Right.
So we don't believe there's really any excuse unless you're bedridden in the hospital. And even there, you can usually do something with your calves or something. So physical activity is really important. That's why I was happy when I called the 92-year-old
in the gym, right?
Exercising. Because he wasn't doing that when I saw him 17 years ago.
Yeah. And one of the important thing that you've mentioned is it's 22 minutes a day. And I think this is a missed opportunity that a lot of people, especially when we talk to our patients, do you exercise? Yes, absolutely. I'll go twice a week. I'll go to the gym. That's not the same as having consistency is huge, right? There's that compound effect.
Yeah, because the oxidative stress amount, like we said earlier, it's changing constantly in the
Right.
body. So it's not, well, only 2 days a week I get oxidative stress, I'll take care of it, go.
Right.
It's happening
Right.
all the time. So you need to be getting some physical activity every day for sure. And then with diet, basically you want foods that are antioxidant, healthy foods. And we have numerous studies now showing if you want to be a vegetarian, okay. But if you don't want to be a vegetarian, that's okay too. Just make healthy food choices. Eat your fruits and your vegetables and more healthy meats. And you can have some dairy. You can have some eggs. So we don't have any radical diets. We fine tune it with 2 genes. The ApoE gene, if you're ApoE4, then we want a high fat diet. We want at least 35% of your diet to be fat. If you're ApoE4, we want 20% or less fat. So we do adjust it with the ApoE gene, and then the haptoglobin gene, we make adjustments. Because if you're haptoglobin 2, one of the reasons it's also bad to carry haptoglobin 2, the precursor protein for it is a substance called zonulin. Zonulin makes every barrier in your body leak, from the airway to the gut to the blood-brain barrier. So those individuals have higher risk for cancers, all kinds of cancers. We're all exposed to toxins every day. They're at higher risk for the autoimmune diseases, rheumatoid arthritis, psoriasis, et cetera, because the antigens are more likely to enter your body. So it goes beyond just the arterial increased risk, and they're higher risk for central nervous system disorders. We believe including even things like autism. So you can reduce how much zonulin you release by avoiding gluten and enhancing the bacteria in the gut as best as you can. So if somebody's a haptoglobin 2, we really want them to be as gluten-free as they possibly can. And we want them eating all those fermented foods. I always recommend the book by David Perlmutter, The Brain Maker, for anybody who carries haptoglobin 2. He doesn't mention the gene in his book, but his dietary advice is perfect for somebody who's haptoglobin 2. It's great. So with the diet, we use those 2 genes to adjust. And one other gene we get from the pharmacogenetic panel is cytochrome P450 1A2. 1A2 is the gene that will metabolize caffeine. It's the isoenzyme for caffeine, because overall, caffeinated products have been shown to reduce not only cardiovascular risk, but the risk of diabetes, dementia, etc. But we do have some studies now where they've looked to see if somebody's a poor metabolizer of caffeine, and it all backfires. So if you're taking in a lot of caffeine, you're a poor metabolizer, then it actually goes the other way with the risk. So if we have an individual who's a poor metabolizer with 1A2, we tell them, it's better if you avoid caffeine. You certainly can still drink coffee. It's good, no matter what. Decaf coffee, really decaffeinated coffee, has great data with everything except stroke. It wasn't significant with stroke to reduce it, but it has good data. But we use that gene as well for that bit of dietary advice. But yeah, the genes are essential. Otherwise, you're treating individuals as the average of the population, and nobody's the average of the population.
Yeah.
So if you want to get great results, you have to know the genetics of the individual.
Yeah. And I'm just curious, you said, you'd mentioned the autoimmune diseases. Have you seen any reversal ones for like, let's say, haptoglobin 2, and have you seen those?
Yeah, great question, because my daughter, she's my nurse. She was advanced nurse at Vanderbilt. I stole her away. She can read EKGs better than I can. One of her best friends, a rheumatoid arthritic, and she's so bad that she travels a couple of 100 miles to see a rheumatologist and on all sorts of drugs for it. When we started measuring haptoglobin, my daughter went to her and said, "Hey, I want you to run this gene test." She did. She was a haptoglobin 2. She went off gluten, started eating all these other foods that enrich the bacteria in the gut. She went off her medicine.
I mean, that seems like another one that everyone with autoimmune diseases should get then, for sure.
In my opinion, it does. I agree. But I'm not sure how many rheumatologists even know about haptoglobin. I don't know. Hopefully they know, but if they know, why don't they run it?
Right.
Yeah.
No, I agree.
I think that word's not out.
Any disease should have haptoglobin gene tested for sure. Yeah.
Yeah. Are there other lifestyle?
Paper on that too.
Yeah.
How many papers do I?
Are there other lifestyle changes that you think everyone should be?
Well, big time psychosocial issues are huge. And like the latest patient we saw, we would argue one of her main issues was psychosocial, is stress. And so we're always talking about mindfulness, meditation, prayer. It works just as well if people are anchored in their religion and prayer. But people definitely need to practice more meditation, mindfulness, prayer, and get rid of that stress.
Yeah.
Stress drives oxidative stress. And we have fantastic, detailed scientific studies showing that.
Yeah. Yeah. A question that I had that I really wanted to ask you was about taking ice baths. So there's a lot of interest in that, and I used to follow the Wim Hof method, which is like a breathing and ice baths, and I just enjoy doing it. But I really I appreciated the idea, and I don't know if it's just an idea or if there's any basis to this, that you have, as you mentioned, like 30,000 miles of blood vessels, 60,000 including the venous system, and
with the veins.
And there's muscles all around those, and they don't really get a good workout unless you expose yourself to different temperatures. So is there anything to the idea that in order to really have a healthy vascular system, you should also be including, if not ice baths, then certainly exposure to different temperatures, or is that not important?
My prediction would be they will generate studies over the next 5 to 6 years showing how that type of therapy reduces oxidative stress. So I think it is going to be shown to be beneficial, and I think the reason will be oxidative stress. Do you have to do it to stay healthy? I don't think so. That 92-year-old type 2 diabetic, he's not doing that. But if you want to do it,
it can be an additional tool.
Yeah, an additional tool if you want.
Yeah.
So it wouldn't be in your mind necessarily that you're strengthening or tuning up the muscles around the vessels, but rather that the cold is actually reducing the oxidative stress itself.
That would be my prediction, and I bet they'll show that with some studies that may be 5-6 years.
Yeah, interesting.
That's fine. You're going to do it. This probably is healthy. I'm not going to run over and jump in my ice cold pool right now. No. Exercise this morning, yeah. I don't miss a day of exercise, probably.
Yeah, that's.
It probably will be shown to definitely be a healthy thing, and like you say, an additional tool.
Sure.
If somebody wants to do it.
Yeah. On to medications?
Yeah, medications and supplements.
So, yeah. When you think about medications and supplements, are there certain meds that, I mean, the big question I think a lot of people will have is statins, because so many people, I think Lipitor is the #1 prescribed medication in the country. Are statins helpful?
Statins are wonderful, and the reason is oxidative stress. And we now even have studies with animals showing how the statins stop the production of the proteoglycans in the intima to trap the cholesterol. And the reason they do that is because they clobber oxidative stress. So it has very little to do with cholesterol and a ton to do with oxidative stress.
Yeah.
Absolutely. So yeah, anybody that we find who has arterial disease, their secondary or tertiary prevention, we know they trapped particles in the wall of the artery. So we want them on a statin to clobber the oxidative stress and try and put a halt to the trapping. Do we need a high dose? No. Most of our patients are on a low dose statin. Or the one that we tend to use the most is actually rosuvastatin, or the brand name is Crestor. I haven't put anybody on a torvastatin for probably 20 years or more. And that was after the Ascot study got published. That was their biggest study with the torvastatin. And several things showed up in that study. One, if you were female, you were actually 10% more likely to have a heart attack on the drug than on placebo. To be fair, it hit the line for significance. So there was no significant benefit, but it was actually on the wrong side even. And then if you had metabolic syndrome or you were a type 2 diabetic, you got no significant benefit from the torvastatin. Well, I've got a lot of female patients, and I got a ton of patients who are metabolic syndrome, pre-diabetic, insulin-resistant diabetic. I'm not going to put them on a torvastatin. So
Yeah.
it kind of just took it out of the toolbox for me. And then they did publish another study called Kashmir that's quite a few years later, and they actually ran it. And this was back in the days when once the study's completed, you did not have to publish it. So they completed it, put it on the shelf, didn't publish it. And then the study with familial hypercholesterolemia came out, and the endpoint was carotid INT. And even though they showed in one arm that LDL cholesterol went down more than the other, they couldn't show any real benefit with carotid INT. And they said, of course, everybody knows when you lower LDL, you clobber the risk. So all this really means is carotid INT is not a valid endpoint. Well, the study Kashmir, their endpoint was carotid INT. So they quickly took it off the shelf, published it. It was a study where basically they had two arms of therapy in women. And they were postmenopausal women. 200 got placebo. 200 got a torvastatin 80 milligram. They clobbered LDL in those women. The carotid INT showed no benefit. So, of course, the spin was, well, this just shows, another study showed carotid INT is no good. Of course, the torvastatin works. And then they did another study, and with really sick people, they had end-stage renal disease, but they weren't so sick they couldn't run a 4-year study with it. And you either got placebo or you got a torvastatin. And the ones that got a torvastatin were twice as likely to end up dying of a fatal stroke.
No.
Well, I don't know. I'm not a fan of a torvastatin. We have studies showing it increases insulin resistance, even though there was this one published recently comparing it to rosuvastatin, and they were implying no, rosuvastatin is worse. But then if you look at who sponsored the study, who did the study, there's a drug company, I think in China or Japan, who was coming out with a combination drug that used the torvastatin. You got to watch for that.
Yeah.
Because rosuvastatin, their biggest study, Jupiter, there was no difference in the insulin-resistant occurrence with placebo or rosuvastatin. And in the Jupiter trial, they showed rosuvastatin works just as well in females as it does males.
Yeah.
So with that kind of evidence,
Yeah.
we're going to use rosuvastatin. You don't have to dose it very high. Most of our patients on it are on 5-10 milligram, and you don't have to dose it every day. It's got a 19-hour half-life. And then we always make sure their CoQ10, their vitamin D levels are good, and that they're sleeping okay. Because you're more apt to get the muscle issues if you have low CoQ10, low vitamin D, or sleep issue. So I'm not saying we never get a muscle issue with rosuvastatin. We do certainly in few patients, but it's nothing compared to what you hear about in the news. But I think it's for several reasons.
If someone's not having any muscle issues while they're taking rosuvastatin, would you put them on CoQ10 anyway?
Yeah, if they're on a statin.
Statin, just CoQ10 across the board if they're on a statin.
Yeah, statin is reduced CoQ10. It's a coenzyme, as you know, necessary for the mitochondria that generate energy. So you don't want to run low on CoQ10. I've never seen a study actually showing it can be too high. Definitely can be too low. But yeah, the statins clobber oxidative stress. That's why they work. They can actually also help reduce the risk of a clot. You know, they've shown that with deep venous thrombosis, statins reduce the risk of that, I mean, about 50%. And they do lower APOB, which we pay attention to.
Yeah.
And then we got tons of studies showing how statins reduce the quote inflammation, you know, that you see from the cytokines and stuff. But of course, anytime you stop the trapping, what are you going to do with that inflammation? You turn the immune system gets turned off. So of course they've got studies showing how they reduce CRP, etc. The reason they reduce it because they stop the trapping. It's a trapping that causes the immune system to kick in and causes the inflammation. And we don't think it's a fair term to say, oh, well, now you got endothelial dysfunction. No, the body's trying to clean up this mess. If you stop it from being trapped, it doesn't need to do that.
Yeah.
But yeah, statins are great drugs. They've been promoted for the wrong reason. And of course, we've got great studies that show exactly what I'm talking about.
Yeah.
With statins, one was a lipid trial done quite a few years ago with pravastatin, a 6-year trial that clearly showed the patients on pravastatin had significantly lower cardiovascular risk for an event. So they wanted to dive in to see why. So they said, is it because it lowered LDL? Or is it because it lowered something we call plaque-2, lipoprotein-associated phospholipase A2, which is one of our inflammatory markers? When it's elevated, we have studies telling us you've got active disease. You're trapping particles. It goes up when there's disease going on. So they looked at that, and they found 59% of the risk reduction was attributed to plaque-2. Lipoprotein-associated phospholipase A2. You want to know how much was attributed to LDL reduction?
I'm guessing not a lot.
0.
Yeah. Shag.
Zip. And we believe if they'd included all of our inflammatory markers, they would have gotten close to 100% of why it works. Because when you reduce plaque-2, you're going to reduce all the other inflammation too.
Right.
But that's why the statins work. They shut down the fire. And they shut down the fire by clobbering oxidative stress.
Are there other medicines that are good for clobbering oxidative stress that people should be on their radar?
And niacin is a good one for people who can take it, and also can enhance the functionality of HDL. The other, quote, secret sauce we have is pioglitazone. That was Actos. And we got a lot of patients on that. They're usually all insulin resistant, but not diabetic. You know, it's a diabetic drug. But when they review the studies on it, it actually helps, and this is published, it prevents the transformation of contractile smooth muscle cells to migratory secretory smooth muscle cells. It prevents it.
Huh.
You want to know what else it does? If you do produce one, it'll kill it. So it's a double whammy. You're talking about a stud for taking care of forming proteoglycans in the intestine. That's pyoglitazine. And obviously they have studies showing how it reduces cardiovascular risk, stroke risk, etc.
Is that something that people that are not not pre-diabetic, should they be looking at that? Is that something that you would want?
We always use it in patients who were pre-diabetic or insulin resistant from the get-go.
Yeah. But what if they're not pre-diabetic?
Well, one of the medicines that 92-year-old diabetics on, when I first saw them, two things I put them on immediately were niacin and pioglitazine.
But how about for people that aren't diabetic or that aren't pre-diabetic? Is that still something to consider because of its effect?
I don't think I've ever put anybody on it who wasn't at least resistant to insulin or pre-diabetic.
Yeah. Okay.
But of course, there are a lot of those people out there who aren't being identified because the American Diabetic Association says all you need to look at is A1C, hemoglobin A1C. And if it's below 5.7%, they're not pre-diabetic. We've got a slew of studies that show how ridiculous that is. The accuracy of that, picking up the pre-diabetes, is as good as picking a quarter out of your pocket and flipping it. Heads you are, tails you're not. And years ago, I even had an endocrinologist of some renown who was a patient, and I kept telling her I want to do an oral glucose tolerance test. I think you're insulin resistant. I think you're pre-diabetic. Well, she's skinny as a rail. She never ate anything. She said, well, look, my A1C is 4.8%. I can't be pre-diabetic. Please. Finally, she did. Her 2-hour sugar was like 180. She was almost diabetic.
Okay. Yeah.
Wow.
So if you really want to know if you're pre-diabetic, you need to go through an oral glucose tolerance test with a 75-gram challenge on your pancreas. If the 1-hour sugar is above 125, you're pre-diabetic. If it's above 150, you're 7 to 8 times more likely to be a diabetic in the next 6 or 7 years. And if the 2-hour sugar hits 120, not 140, 120, you've already got 66% of your beta cells are fatigued. Dr. DeFranzo published that in the journal Diabetes probably 12 years ago. Still the standard of care, oh, if your 2-hour sugar is under 140, you're okay. I mean, what's going on? If it's 120, you're already well on your way to being diabetic. 2/3 of the beta cells are already fatigued. So, we prevent diabetes too. The way you prevent diabetes is finding out somebody's headed there.
Right. Yeah.
And a ton of those pre-diabetics are being missed because of the A1C, which the ADA backs up. Oh, that's all you need. Don't they look at these studies? I mean, they're published.
Yeah.
The A1C misses about half the people. About half of them. And we now know at least 1 in 3 American adults are pre-diabetic. We also know 9 out of 10 don't know it. Diabetes is the fastest growing disease in the United States.
Yeah.
I would say
That's
one
crazy.
of the reasons for it is ignorance.
Yeah.
Oh, it's just because people aren't exercising, they're eating too much, blah, blah, blah. Well, look, if you tell somebody, you show them a test, look, you're well on your way to diabetes. Now's the time to turn this train around. A bunch of people are going to follow your advice.
Yeah.
But when they don't know, and all of a sudden they walk in someday and they're diabetic, oh, you're diabetic. And then, this patient we saw recently, she said her primary care doctor told she and her husband There's only two categories. You're either diabetic or you're not.
No.
What? It's a continuum of risk.
Yeah.
You've got years and years to point out to somebody, hey, you're headed for diabetes.
Yeah.
You can do this, 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 and this. And periodontal disease helps prevent diabetes.
Right.
Because diabetes, insulin resistance is driven by, guess what? Oxidative stress. When you have oxidative stress, the muscle cells can't take in the sugar from the bloodstream. We've got the scientific studies to go into the details of biochemistry of that.
Wow. I was really...
sleep causes prediabetes, periodontal disease, low vitamin D. All those things that cause oxidative stress are related to increased risk of diabetes. So there's a slew of things you can do. But I think a lot of healthcare providers are like, oh, well, they're fat, they eat too much, they don't exercise, so heck with them. There's a lot of other things that play a role in that, and the patients aren't being informed. And if they take action on some of those, maybe they don't need to lose a ton of weight. Yeah, maybe they need to be a little more physically active, but they don't have to become a gym rat. You know? But all of these things play into it. Have they had high-risk periodontal pathogens checked by the dentist? If they have high-risk periodontal pathogens, they're getting oxidative stress, and it's well documented, they're more likely to go on to diabetes. I mean,
if they have...
Really, I mean, again, the good thing, in my opinion, is we now live in an age where we have the science to shut all this stuff down. And yeah, they're going to keep coming out with fancier drugs, but we've got enough science now to shut it down. And so it's just...
If somebody has those high-risk pathogens, what do they do about it?
Yeah, that's up to the dentist, and there are lots of things they can do. Of course, deep cleaning and scraping, and then they have lasers can destroy those bacteria, but if you don't do the right preventative stuff, they'll come right back. You have trays that can be made to fit tightly over your gums. All the high-risk pathogens are anaerobes. Then you put hydrogen peroxide in the trays. That creates oxygen. It's like a hyperbaric oxygen chamber. And it'll help shift and kill a lot of those high-risk pathogens. The side effect from that is it keeps your teeth white. And then they've shown in studies you can use a water pick, like in the shower, and just put a little bit of Clorox bleach.
Clorox bleach.
2 cc's in a cup, and use a water pick. It kills all those high-risk pathogens.
Huh.
So you can do it.
Yeah.
I thought you would say hydrogen peroxide. I thought you were going to say put hydrogen peroxide in it, but you were saying bleach.
Yeah.
Yeah, bleach. Yeah, I've been doing it for years. So I believe in John Kennedy, the senator from Louisiana. I love the guy. He's got a great saying. He says, you do what you believe. What you say is just conversation. So everything I've been saying, I believe.
Yeah.
Because the reason I started down this path 25 years ago or so, my family history is horrible. I was 5 years old having lunch with my father's mother. He was 65. She had a massive heart attack and died. It was just myself and my younger brother. My mother, my brothers, my other grandparents. So one reason I do...
Very personal. Yeah.
Yeah. The great news again is you can shut down arterial disease.
There's a lot of buzz around people taking metformin for longevity and that kind of stuff. Does that have anything to do with...
I'm not a big fan of that. We know the main reason metformin works to lower blood sugar, it blocks one of the enzymes necessary to put sugar out of the liver. What's that going to? There's no evidence it reduces oxidative stress.
Mm-hmm.
And actually, we have evidence to the contrary, that it doesn't reduce oxidative stress.
Mm.
And if you don't reduce oxidative stress, you're not going to live longer.
Yeah.
So I'm not a huge fan.
Are there any other medicines that are on that are on or should be on people's radars?
Well, I mean, most of the stuff, we use very few medicines.
Yeah.
Again, we view medicines as poisons. They're all poison. And they can do more harm than good.
Sure.
So when we pull one off the shelf, we're betting it'll do more good than harm. And then we're going to do some measurements, objective measurements in a relatively short period of time to see if indeed that's the case. We're not going to tell, I'll start taking this, I'll check again in a year. No, we're going to check again in a few months and look at some biomarkers that'll tell us where we're right or where we're wrong.
Yeah.
So we don't use a lot of medicines. We do recommend healthy diet, exercise, meditation, prayer, vitamin D. A ton of people are deficient in vitamin D, so we use a lot of vitamin D. As I say, we use a lot of niacin. We do believe in omega-3s, and if somebody wants to eat salmon like 3 or 4 times a week, well, they need to take omega-3 for it, but most people aren't eating that much salmon. Cinnamon has great data for lowering the blood sugar, even after a meal. They've got great randomized double-blind placebo-controlled trials showing if you take cinnamon before you eat a meal, your blood sugar won't go as high. Chromium reduces insulin resistance. So we use a lot of those supplements, which are cheap.
Yeah.
And the risk from those is very little. We have a lot of people on vitamin K2, MK7 that's been shown to reduce insulin resistance, and also, as you probably know, it shifts the calcium into the bone, helps keep the bones healthier. So
there's also been some
a lot of medicine.
What, beetroot juice.
Oh, beetroot juice is great for lower blood sugar. It increases nitric oxide,
Right.
which is the best food for the endothelium of the big vessels. If you get down to the microvasculature, it's actually more hydrogen peroxide that dilates, but nitric oxide is really good.
Mm-hmm.
Yeah.
So,
Do those beet chews work as well as the beet juice, or do you have to suffer through the beet juice?
If I had a blood pressure issue, I definitely would consider it.
When it comes to blood pressure, what should people be looking for as an optimal blood pressure?
Yeah, you can't give a carte blanche answer to that because there are some people who've lived long enough, they have some bit of obstructing disease in their arteries, in the coronaries or the brain. So they do have maybe a plaque that grew as far as it could this way, and now it's grown in and maybe 70, 80% into the vessel. And so to get the blood around it, to perfuse the brain or the heart adequately, you need some pressure.
Mm-hmm.
So we know from the studies that once the systolic goes above 120, your risk of dementia and Alzheimer's continually goes up. So we've always wanted, when we could, to keep the blood pressure below 120. Now some studies are even indicating 110 over 70 may be an even better cut point. But if you reduce, the heart feeds itself, of course, during diastole. So if you tell a patient with significant heart disease, I'm going to drop your blood pressure down to 110 systolic, their diastolic very well may fall in the 50s. That might kill them. That might not be enough pressure to perfuse the heart. But in a healthy individual, definitely under 120 over 80. Perhaps the data will end up showing under 110 over 70. But if you have disease, you have to modify that. So.
Okay. And one more question on blood pressure, if it's okay. How bad is salt for high blood pressure? Is that, because I hear conflicting opinions on that.
Yeah, there's certainly some people who are very salt sensitive, and if they add much salt at all, their blood pressure is going to shoot up significantly. There do appear to be individuals who they're not that salt sensitive. So we always give out the recommendation, hey, look, don't just grab a salt shaker. Salt foods naturally have tons of salt in them, probably getting all you need. But if you do, you better be paying real close attention to your blood pressure. And if it goes up, absolutely have to cut it way back.
Yeah.
So, again, personalized care, not just everybody. So you can measure it. We have all our patients measure their blood pressure routine, and send us in that information. So it's too high and you're using some salt. Hello.
Right. Yeah. Yeah. You have to modify for yourself to see what happens to the blood pressure. Yeah.
And if you do know that you're sensitive, there are ways around it, like using lemon juice and still getting that taste and avoiding the actual salt.
Yeah. And one thing I use, it's called LITE salt, Morton, and it's got a much higher percentage of potassium than sodium in it. And we now have studies showing that if you use that type of salt, it lowers your cardiovascular risk. Because a lot of people get a little too low in potassium, and they're getting too much sodium. So this light salt, and to me it tastes good. I really don't notice a difference. LITE. And there are other products similar to that.
There was one, I think, DNA test that you recommended in the book that you thought everyone should get, which was the PGT test. Is that right?
Yeah, that's a pharmacogenetic.
Oh, okay. Could you describe that? And
that has all the isoenzymes that metabolize any medication that we might want to use, along with some supplements like caffeine that we might recommend or not recommend depending on your genetic makeup. Again, like the 1A2, but it contains like the cytochrome P450-384, which metabolizes a lot of drugs. TC19, which metabolizes Plavix, et cetera, et cetera. Yeah. So once you have that, you can fine tune, if the patient's on a prescription medicine, even some supplements like caffeine, you can fine tune what they should be on.
Got it.
Yeah.
Right. Yeah.
There's a lot. It's so exciting because it shows how much control you can have if you sort of learn about it. And yet at the same time, it's a little frustrating because so much of this is just, you have to self-advocate to an extent, right? That's why it's so important to get the word out with your book, doing podcasts like this.
Thanks. Yeah. And then, so with that genetic test, just one other caveat there, I'm sure you know it. Genetic tests are the cheapest tests on the planet. You're one and done.
Yeah.
Where all these other tests, they might sound cheap on the surface, but then you have to keep repeating them. So genetic tests by far and away are the cheapest tests. In our opinion, basically every human should have their complete genetic profile checked. Why not?
Yes.
It's cheap. And then you can really hone in on personalizing their care.
Yeah.
Now, is that true? Some of those tests are actually available commercially, right?
Oh, yeah. Yeah, sure.
Without a prescription. So people can...
Yeah, that if you get 23andMe, it doesn't give some of the SNPs that we want to see, but then you can have that analyzed through another company and get those. So,
okay, right.
Yeah.
Oh, that's interesting.
Testing's not that hard to get anymore.
Yeah. That's exciting. It seems pretty clear that it's the future of medicine in so many different ways. And I think, for me personally, I can say I didn't realize how far it had already advanced, within cardiology. It's exciting to
I feel bad. The cardiologists come to our course and they have the same reaction. But everything we do is based on published science in excellent journals. So But it's interesting with the science because we do a reunion every year, Bale method reunion. Got one coming up in Scottsdale, Arizona in April, and we always have a theme for it. So my partner, Amy Donine, and I were talking several months ago and just kind of, we almost have to pinch ourselves. The results we've gotten are just incredible. People don't have heart attacks, strokes, develop all these other issues. And so we're saying, golly, what? We don't even use that much medicine. Why are we getting these results? And I said, well, of course, our science is solid. That has something to do with it, but it reaches way beyond the science. You're not going to get great results just with science. So what we both agree with is we form partnerships with our patients. It becomes a team effort. And so it does reach beyond the science to get the results that we get. It's not just the science. We find out what motivates the patients. Why do you want to do this? Maybe it's a grandchild. Maybe it's a wife. Maybe whatever. And then when you visit with them, how's your grandson doing?
Yeah.
But you form a partnership with the patients. And unfortunately, in the conventional healthcare system now, doctors are driven to see so many people each day, they haven't got the opportunity to form that type of relationship.
Yeah.
And I think it's vital.
Yeah.
Well, that relationship is addressing a number of different factors, right? It's addressing the psychosocial, just in itself. It's addressing the psychosocial aspect of it. And also, we know from psychology, right, that the school of thought of the psychologist you're working with is not as important as your relationship with that psychologist. Your outcomes are going to be based on that. And we see that throughout their even musculoskeletal field, where the physical therapist that they form a relationship with is not, their excellence is important, but the relationship is really what's going to be a predictive factor in how well they'll do and how much recovery they'll see.
Absolutely, you got it.
Yeah.
So we're blessed to have plenty of time with our patients because we don't go with insurance. People pay us a fair price, and nobody's ever complained about what they pay. They say we don't charge enough, but we charge enough where we can spend all the time we want with the person.
Right.
A new patient we saw this week has spent the whole day with the patient and her husband.
Wow. Yeah, that's
together, and it was fun.
right. Yeah, it harkens back to a different age of medicine, and we're anxiously awaiting your affiliate office in New Jersey.
Yes.
Probably will have some. We got providers all over the country, so we may have somebody in New Jersey right now. I can check. I know we got an excellent cardiologist at Mount Sinai in New York.
Oh, that's real close.
Yeah.
How do people find people who have been trained in your method? How do people go about finding
On our website, they can find out. But yeah, if you really want this, I would highly recommend you plug into Alon Gittig, Gittig. He's at Mount Sinai, cardiologist in New York.
Nice.
He's doing
Okay.
an excellent job.
Mm-hmm.
They're
Oh my God.
Well, and we'll definitely.
affiliated with Mount Sinai anyway, aren't you?
Yeah.
Yeah.
Yes. Yeah. Yeah. We have an affiliation with them.
But Alon, Alon Gittig,
Okay.
Gittig.
Okay. Yeah. Yeah. Great.
He knows all this. As a matter of fact, he's helping us come out with our next publication, which will be about statins. He's going to be the lead author on it. So
Nice. Right.
And so we'll definitely put a link to your website, but if you could mention the website now.
yeah, it's Bale, B-A-L-E, Doneen, D-O-N-E-E-N.com, BaleDoneen.com. My name's Bradley Bale, B-A-L-E. My partner's name is Amy Doneen, D-O-N-E-E-N. So BaleDoneen.com.
Yeah,
Awesome.
perfect.
And we'll get it up there on the.
We'll have the link,
that, yeah.
absolutely. And we definitely recommend people pick up your book.
Oh, it's a great book.
The
It's
healthy,
really
healthy
interesting.
heart, healthy brain. There's a
Yeah.
lot more detail of what we've gone into.
Yeah.
Yeah, so it's a great read.
It's a great read. Brad, you've been so generous with your time. Thank you so much.
Thanks for having me on. It's great. And if you do get hold of Alon, tell him I said hello. He's a great guy.
We'll
We
definitely
will. We
Yeah.
will. We absolutely will. Friends, thank you for your attention. We hope you've enjoyed the conversation. If you find value, please remember to hit the like button to help us with our YouTube algorithm. Consider subscribing to the channel and turn on the notifications so you can stay up to date with everything going on with the channel. And please leave us a comment, let us know what you thought about this show and also what you'd like to hear about in the future.